I am Varun Puri. I am a professor of surgery at the Washington University in St. Louis and a practicing thoracic surgeon and health services researcher. Assessment of lung function and its response to surgery or other forms of treatment for lung cancer is a critical component of managing each patient and tailoring therapy to individual patients, particularly in regards to surgery for lung cancer. I'll tackle what is lung function as the first component of this particular investigation. Lung function is typically measured by a test called spirometry, which can be conducted either in the office using a small handheld device. It's a fairly easy test to do and can be conducted in only a few minutes. And with minimal training, one can interpret the results of the office spirometry. Office spirometry gives us two important values. One is called FEV1, which is the forced expiratory volume in the first second of exhalation. And the second is FVC, which is the forced vital capacity. It does not provide any other detailed information. However, the second type of spirometry, which is called lab-based spirometry, often conducted in pulmonary offices or in the hospital setting, is conducted in a more formal environment. There, in addition to getting lung volumes, such as what one might expect with office spirometry, one also gets an assessment of the gas exchange function of the lung in the form of DLCO, which is the diffusing capacity of the lung for carbon monoxide. Now, both of these parameters are important preoperative or pre-treatment indicators of lung function and are assessed or predicted post-operatively or post-treatment also. They are normalized based upon the patient's height, weight, age, gender, etc., to values that have been collected over the decades from the general population. And since they're normalized, one is able to look at them in the form of percent predicted. For example, someone who has lung cancer and has years of smoking history behind them may have an FEV1 and a DLCO approximately 60 to 70% predicted, which is a fairly common number that we see in patients that we're assessing for surgical intervention for their lung cancer. The impact of surgical resection on lung function is something which can be scientifically assessed preoperatively and predicted in the post-operative period. So what's important to understand is the short-term impact of surgical resection on lung function is different than the long-term impact. How one divides the lung up into parts is called bronchopulmonary segments. And there are a total of 20, or some older textbooks would say 18 bronchopulmonary segments. And there are 10 in each lung, with the right lung contributing to 10 and the left lung contributing to 10 in different lobes of the lung. For example, the right middle lobe has 2 segments, the right lower lobe has 5, and the right upper lobe has 3 segments. While in the left side, the lingula, which is a part of the left upper lobe of the lung, has 2 segments, and the remaining part of the left upper lobe also has 3 segments. The left lower lobe, similar to the right side, has 5 segments. So now we have about 20 segments of baseline lung function that we are assessing. Based upon what the expected operation is, one can predict how much lung tissue one is expected to lose. For example, if one is conducting a lobectomy on the right side, which is a middle lobectomy, then one is going to lose only 2 bronchopulmonary segments, as opposed to, say, a right upper lobectomy, where one would lose 3 bronchopulmonary segments, or a lower lobectomy, where 5 segments would be excised. So based upon preoperative lung function, one can assess what the predicted postoperative lung function would be. As an example, let's look at a patient who has a preoperative FEV1 or DLCO, say, of 100% predicted. And if you remove 3 bronchopulmonary segments out of 20, you expect approximately 1/6 of that patient's lung capacity or pulmonary function to decline in the early postoperative period. However, the story really does not end there. In most people, this short-term decline actually reverses itself to a significant degree in the long term. And this is through a mechanism called compensatory response or compensatory lung growth. A number of studies from Japan have studied how the lung responds to resection. And through both anatomic studies as well as imaging studies, they have shown that the lung increases in volume and weight long-term after lung resection. This response is particularly robust in individuals who are not smokers and who are younger, particularly people less than 60 years of age. So one can expect that the long-term improvement in the decline that one would see in the short term after lung resection would be less so in someone who's a non-smoker or belongs to a younger age group. Importantly, there are certain tests one can do in the preoperative period to assess what the blood flow to each lung is, which also helps predict the postoperative expected lung function for FEV1 and DLCO. As we know from anatomic studies, the right lung receives a little bit more of the blood supply under normal circumstances. So when you look at the perfusion scans in lungs, which is a radionuclide scan where you label the blood and you see the blood flow into both lungs, the right lung receives between 50 to 60% of the perfusion, and the left lung receives between 40 to 50% of the perfusion. So there's a little bit greater loss of lung function with right-sided resections compared to left-sided resections, particularly if a pneumonectomy is being considered. There are certain special circumstances where all of our calculations really don't hold much weight. For example, in patients who have an obstructed airway, imagine a patient who has a right upper lobe non-small cell lung carcinoma completely obstructing the right upper lobe bronchus. And when you do a right upper lobectomy, you practically lose no lung function in the long term because that lobe of the lung was not getting any aeration at all and was not contributing to the patient's preoperative lung function. Similarly, if a patient has a tumor which has caused significant compromise of the pulmonary artery and has very little perfusion to the part of the lung that is going to be excised or resected, so that lung is really not contributing any significant lung function. So you really would not lose much lung function. Additionally, in many patients, and patients with lung cancer often have emphysema, upper lobes contribute less to lung function than the lower lobes. And there's a concept in thoracic surgery called lung volume reduction. So this is an operation or other endobronchial forms of treatment that can be applied for this patient population, where you reduce lung function of the emphysematous lung, thereby improving the lung function of the part which is functioning better. And typically, upper lobes have have a significant degree of reduced lung function in patients with severe emphysema. So the loss of lung function after resection of upper lobes is much less than one would expect. Finally, the long-term recovery of lung function depends on exercise that the patients are involved in postoperatively and smoking cessation after lung resection. Importantly, since stereotactic radiation or other forms of radiation therapy are being commonly utilized for treating patients with early stage lung cancer, particularly a high-risk group that may have compromised lung function, it's important to know what predictive lung function would be after treatment with radiation therapy. Broadly speaking, sublobar resection, which is resection of either a wedge or a segment of lung tissue, and stereotactic radiation therapy have relatively similar contributions to decline in lung function when one might think anatomically. So our group conducted a study several years ago where we took pooled data from 3 national studies. This was the ACOSOG Z4033, which was a study for radiofrequency ablation of lung tumors, the RTOG 0236, which was a study looking at stereotactic radiation therapy for early stage lung cancer, and the ACOSOG Z4032, which was a study of sublobar resection, that is a wedge or a segmental resection for patients with compromised pulmonary function. So our group assessed the DLCO change pre and post treatment, and we found that there really wasn't much difference between sublobar resection and SBRT in the short term. And at the 3-month mark, surgical patients had actually recovered their lung function somewhat better than patients undergoing stereotactic radiation, although the difference was small and likely not clinically very meaningful. Additionally, a recent Japanese study also looked at 70 patients who underwent radiation therapy. And this was stereotactic radiation therapy for either lung cancer or metastatic disease to the lungs. They obtained PFTs pre-treatment and at 18 to 24 months. And they noticed that the FVC, which is the forced vital capacity of the lungs, declined to a modest degree. And this was associated with what's called the PTV, which is the planning target volume. So the greater the PTV, the greater the decline in FVC, which sort of makes anatomic sense, as if you're radiating more lung, you're more likely to lose more lung. Also, they, however, saw that there was no really dose effect relationship on PFTs. So higher dose of radiation to the same volume of lung did not lead to a greater decline in lung function after radiation. In addition, the group at MD Anderson has published a number of studies looking at predicted postoperative or expected post-treatment post-radiation therapy lung function in their patients. And they've noticed that there is a between 4 and 6% or 4 and 7% decline in various lung parameters, including the FEV1, DLCO, and FVC. Finally, it's important to realize that these are just lung function parameters that one can objectively measure. However, an important component of a patient's respiratory capacity is the actual function of the lung that the patient has. And radiation pneumonitis or pneumonitis associated with immunotherapy or chemotherapeutic agents is also an important component of decline in lung capacity or function, which may not be objectively measured after, say, radiation therapy induced lung injury or surgical resection.